Good evening, guys. I'm gonna go ahead and get started straight up 6 o'clock because it's a pretty lengthy chapter. When I pre-recorded the second part, it's pretty lengthy itself. So go ahead and get started early. Just to let you five know that I will give you an extra day on this test because it's not going to get uploaded until probably late tonight, first thing tomorrow, and then you'll have the second part to watch. So I'll probably give you an extra day, maybe a day and a half to get this test completed. So here's special populations. When we talk about pediatrics, pediatrics is very challenging sometimes. I mean, it's pretty lengthy because of the depth that we have to go into just as a basic level to dive off into pediatrics as we go forward. Patients with special challenges, we need to recognize and reporting abuse and neglect. We talked about that. Healthcare and implications of abuse and neglect. That'll hang on one second, guys. So we'll go over the trauma like it is in every single other part of the chapters have been for trauma wise. We're on the right page. We'll talk about recognizing management and the trauma, what to look for in pediatric trauma, how to recognize that, and why we need to act so fast. Pathophysiology assessment, management of trauma in the pediatric patient. We'll dive off pretty deep into that. And again, pediatrics are specialized. It is a special process that we have to do because remember, they're little bitty bodies, and then we're turning around and trying to take care of them pretty fast. They will compensate, decompensate, go into shock, and go into a traumatic cardiac arrest rapidly. Something we have to be careful for because of how fast they compensate. All right, so children differ anatomically, physically, and emotionally from adults. I pray that y'all already know that. The illness and injuries that children sustain and their response to them vary based on an age or developmental levels. It is important to remember that children are not small adults. They are their own. Depending on his or her age, the child may not be able to tell you what is wrong. They may not know how to relate that into words. Parents or primary caregivers may be stressed, frightened, or behavioral irritability. They can be, I mean, I can understand my baby is injured and upset, and then these people show up and I don't know, maybe we didn't get off on the right page. I can understand the irritability of them. All right, for these reasons, pediatrics, the specialized medical practice devoted to care for these young patients can be very challenging. It can be very challenging. Once you learn how to approach children of different age and what to expect while caring for them, you will find that treating children also offers some very special rewards. I like dealing with pediatrics. I don't get to deal with them enough because of what I do, but dealing with them challenges me as a care provider. They allow you to build a very broad spectrum of what's going on to how to treat them to improve their care. Their innocence and openness can be appealing. Sometimes they will let you into their little circle a lot faster than an adult will. And children often respond to treatment much more rapidly than adults do. Remember that we're talking about the blood volume and their little bitty bodies versus ours is going to be dramatically different. So these children can respond very differently when we go to talk about how they react, how fast they compensate. So remember that it's not just something that we're saying, oh, well, they're different. Well, yeah, because they are. When you think about the volume of fluids in their body versus the adults, we can compensate a little bit longer than they can. So that's part of the reasons why we have to act so fast. So communication with the patient and the family. So we want to care for the infant and child means that you must care for the parents as well as the caregiver. They are just as important as that particular child. Family members or caregivers often need some emotional support depending upon what particularly happened to them. A calm parent usually results into a calm child. A parent can often assist you in the child's care. They can assist, they can make the child understand what's going on. You have a calm parent. Most of the time you have a child that's very receptive to you and your care and your treatments. An agitated parent means the child will act the same way as which will make the child's care more difficult. Remain calm, efficient, professional, and sensitive. I always have a thing when I take care of a pediatric patient, and I tell my parents, hey, listen, so as long as you stay calm, as long as you act of carrying abilities and you can act as an adult, I will let you ride with this child. Other than that, you will not ride with the child because you're going to change the way that this outcome is going to take place. If you're hysterical, your child's going to be hysterical, and it's not going to be very easy to treat him and or to take him to a facility where there's a ton more people. So I need you to get your act right. And it's not that I'm trying to be ugly. I'm just trying to set guidelines so these parents understand. So growth and development. So here, probably y'all should know this. If not, you should write this down. Many physical and emotional changes occur during childhood. We've talked about that, how you break out your toddler. Your infant is your first year of life. Y'all should know that from past chapters. A toddler is from age 1 to 3. Preschool is ages 3 to 6. School-aged child is 6 to 12, and an adolescent is age 13 to 18. Y'all need a minute to write that down. Y'all are more than welcome to, but y'all should already have that information for some past chapters. My clicker is not working. All right, so the infant. So infancy is usually defined as their first year of life. So our infant, once they have their 1-year-old birthday, they become a different age group. So the first month after birth is called the neonate and or newborn period. 0 to 2 months. Infants less than 2 months spend most of their time sleeping or eating. Infants cannot tell the difference between parents and or strangers. And crying is one of the most modes of expressions because that's all that they know to do. If something hurts, they cry. If they're hungry, they cry. If they're happy, they smile, and they potentially cry because they don't know how to express themselves. They don't have these facial expressions yet. They have not learned those. So an inconsolable infant, after all obvious needs have been addressed, could be a sign of significant illness. Their heads have relatively large surface area, which predisposes them to hypothermia. So what we know we need to do is keep their heads covered, keep them warm as possible, and can try to keep our treatment just as fast as possible and put those clothes back on to try to keep them warm. 2 to 6 months can recognize their parents or caregivers and turn their heads toward a loud sound that are familiar voice. Persistent crying, irritability, or lack of eye contact can be an indicator of serious illnesses, depressed mental status, or delayed development. You can check the fontanelle, where the little hole is in the top of the part of the head, if it's sunken in, or if it's bulging, can give you obvious signs also. 6 to 12 become mobile, which predisposes them to physical danger. Places things in their mouth, leading to choking and poisoning. I don't know who all has children here, but I can tell you every single thing goes to their mouth. They want to put everything possible in their mouth. They may cry if separated from a parent or caregivers. Sometimes older kids do that too. And persistent crying or irritability can be a symptom of serious illness. When we start assessing them, begin assessment by observing the infant from a distance and get your general impression. Start picking that up when you start to become in contact. Let them see you potentially not be as scared to them. Let the caregiver continue to hold the baby during your physical assessment. Provide as much sensory comfort as possible. Do any painful procedures at the end of your assessment period. Complete each procedure effectively and avoid any type of interruptions. Explain each procedure to the parent or caregiver before you perform it because the procedure and the infant's reaction may be upsetting. Most of the time, if I'm going to start an IV on the infant, I'm not going to let the caregiver hold them. I will lay them on a stretcher and or couch or somewhere like that that is more neutral. I'll let the parent be in the area. If they can't, if they're kind of rowdy, it's going to be different. I'll just take the infant to the truck and work from there. So a toddler. So after infancy becomes a toddler at the age of 3, and toddlers experience rapid change in development also. We know that they're learning things. We know that they're picking up. They're starting to create their own individuality. 12 to 18 months, because they are explorers by nature and are not afraid. In this age group, injuries do increase. Because of the lack of molars, they may not be able to fully chew their food, leading to them to becoming start choking. So that is another thing. We start to get these calls on infants that choke or turn blue and all that, and they think that their baby is in cardiac arrest. Yes, that can happen. Hang on one second again. Back. Or hasn't left. So in the 12 to 18 months, they become more explorers by injuries. So obviously we know their injuries do increase there. I already talked about that. We were done on that slide. Let's go to this one. All right, so an assessment. You may have stranger anxiety. These kids are going to be like, oh no, stranger danger. They haven't been taught that yet because they're very innocent. They don't see the dangers in people. They don't judge. That's the great thing about kids. They're wonderful. They're awesome. And I love dealing with babies. All right, so they may resist separation from the caregiver just because they don't know. They're not used to leaving them. They demonstrate the assessment of a doll or stuffed animal first as possible. Let the child see what's going to happen. Toddlers can have a hard time describing or localizing pain. Again, it hurts all over, like right in this area, like all over. Those are kind of some of the answers you're going to get. Use visual clues or the Wong-Baker Faces scale. They see that, they understand, they can relate that to pain. Begin your assessment at the feet, away from the location of the pain if possible. Persistent crying or irritability can be symptoms of serious illnesses or injury. Previous medical conditions they may experience and lead them to hesitate towards you. They may not want to because they relate to what has happened to them, as it's going to be pain no matter what. If a patient or caregiver is unavailable, reassure the child and use simple words and to calm them soothingly. So what we're trying to do here is, while we want to start at the feet, we got to build trust. We got to get these children to trust us as strangers and just not know what we're doing, who we are, how we act. So if we start away from their face and their hands, we can build their trust, because we can hopefully not cause any harm because of particularly where the injury is. And then we can build the trust and work forward from there. So that's why we want to start at the feet and work our way up. Preschoolers are ages of 3 to 16. They do have a very, very vivid imagination. They're going to be a little bit more fearful to pain. They may believe injury is a result of earlier bad behavior. They think if they did this, it's going to be pain. You know, they have who knows what those babies are thinking. Because at that age, they have all these cool ideas. And I mean, I miss my kids talking like that and having those imaginations, because it just shows you how vast and awesome that these kids are. So when we do assessment on preschool-aged children, can understand directions and be very specific in describing the painful areas. Despite increased ability to communicate, much of the history must still be obtained from the caregivers. Communicate simple and direct. Appeal to the child's imagination may facilitate the examination of the process. It may help you to gain access. It may help you learn how to treat these children, and they may give you more information about things. Do not lie to any patient at this age. It is hard to regain a lost trust. The patient may be easily distracted by games or toys or just other types of conversations. Begin the assessment again at the feet, working our way up, gaining that trust. If you use adhesive bandages to cover the site of an injection or other small wound, they may, I used to always keep like a box of multicolored or multi-type of Band-Aids, and you have different figures on them, and I let them pick those out. Those were good for them. They could pick them out, and it just made the treatment go a little bit better. Modesty is developing at this age, so keep the child covered as much as possible. Don't let them feel like you're exposing them or leaving things uncovered. So now we move into our school-age kids, 6 to 12. At this stage, children have begun to understand death is final, but their understanding of what death is and why still occurs to be unrealistic. My daughter, she just turned 9 today, so today is her birthday. I can't believe I have a 9-year-old. She experienced death with my mother at the age of 6. So she deeply understands that. She truly knows. She's asked a lot of questions, and I encourage my kids to ask those questions. That's hard for them. She still talks about things and makes these impressions and says things about mom and all this and that. And we encourage that. So children do understand that that is the end stage, and they feel that death happens when they were bad, or when they get really sick, or if their parents get really sick, that they think that that's going to cause from it, because that's what they see. They see family members pass because they were super sick or things like that. So that's what's embedded in their heads. So we have to remember that. When we go to assess them, it begins more like an adult assessment. We start talking to them, we gain their trust, and to that child. We don't just talk to the caregiver or the parent. We talk specifically to the child and kind of look at the caregiver for like, is this true? So the child is probably familiar with the process of a physical exam because they've had this going through doctor's offices, school visits, and things like that. Here, we are going to start with the head and move to the feet. So this is where it starts to change at your age 6. If it is possible, give the child's choices. For example, ask only the type of questions that let you control the answer. So I asked them, do you want to use this non-nasal cannula or this non-rebreather for oxygen? You have to have one, so I'm going to let you choose which one you get. Those particular things are very beneficial because it allows us to still get our point across and to let them win because they're winning the answer. They make the decision. Those kids, like, wow, I made my own decision on how I'm going to get something. That's right. That's how it's supposed to happen. So it just helps us out. All right, allow the child to listen to his or her own heartbeat through the stethoscope. I love doing that. It lets these babies learn. These children can understand the difference between physical and emotional pain. They know, they get these things. Give them simple explanations about what is causing their pain and what will or can be done. Ask the parents or caregivers advice about which distraction will work the best. If you're going to advanced level school and you start to, now it's time to start that IV, you need to find things that distract them. We had to do that to some adults sometimes in starting IV. So it's not just children, they relate to things differently. So adolescents 13 to 18, whew, man, I'm gonna tell you. So these, I have 2 in this age group, and sometimes like old Bill Cosby say, I can take you out this world as fast as I brought you in. So they are physically similar to adults, but they are still children on some emotional levels. Time of experimentation, and they do risk-taking behaviors. They start to do peer pressure here. They start to, I dare you to do this, I dare you to do that. Well, yes, but they don't know what the potential full-scale outcome can be. So that can be just as disturbing until you get to a child too. On assessments, adolescents can often understand very complex and treatment options. My soon to be 14-year-old, well, heck, he is 14. He can understand in more depth of a conversation and more details than my 18-year-old. It's not to be any different. That's just their different abilities. It's weird to watch. It's crazy. And then he can translate it over and you're like, yeah, like he really just got what I meant, like 100%. So as an EMT of the same gender should perform the physical examination if possible. This is to lessen the stress of the event. If it is possible, then let's do that. If it's not, then we just carry on with regular business. Allow the adolescent to speak openly and ask questions. Risk-taking behaviors are common at this age. We know that they will try things. They will try to do this or that, and they sometimes can cause a lot of damage to themselves. All right, so female patients, we may consider them to be pregnant when we get into these certain age groups. Adolescents have a clear understanding of the purpose and meaning of pain. So if they are of childbearing age, we have to assume that they are pregnated until proven otherwise. It's the same thing if I was to take care of any of you ladies that's in this program and I'm your care provider and you start to have abdominal pain, lower back pain, trouble urinating, those things right there, you're going to tell me, I'm going to tell you, I'm going to go ahead and just assume that you were pregnant until proven otherwise. Well, unless that female, one of you ladies says, I've had a full hysterectomy, there ain't no way. Well, then we're probably going to go with you having abdominal pains. So we have to think that as long as they're of childbearing age, these kids may potentially be pregnant. That is, it can be scary as a care provider. So we have to be careful how we address that too. All right, so the body is growing. It is changing very rapidly during childhood. They start to have this pre-puberty. They start to have, the females will start to have the buds in their breast. All these things start coming along, and it's new to them too. They don't know what's going on. I don't know what to do. So we have to understand that the physical differences between these children and adults, sometimes we can relate to them and tell them what to expect or potentially what's going to happen and help them get it from an outside source. We also have to be very careful when we do that we don't overstep our boundaries and potentially invade in on their religious rights and all those other things. So it is very cautious, but we can assist them in some of those relations. The respiratory system, we know that it is anatomically the same, but the size is different. We know that their lungs are smaller. The heart is higher in the child's chest. We know those. But when you look at them, they have the same parts. All those parts are still there. It's just newer versus older. It's grown. The adult is the older part, the child is younger. So all of these things are there. If you can see in this little picture right here, the biggest difference right here is just the tongue size in the child versus the adult. That's one of the bigger changes that we see that we have to be careful for. The glottic opening is higher and positioned more anteriorly, and the neck appears to be non-existent. So look here. So we're saying our glottic opening is higher, and so you see that it sits a little bit lower down in the neck here. That's what we're trying to say there. All right, a child's development in the neck gets proportionally larger as the vocal cords and the epiglottis achieve their anatomically correct adult position. It's gotta grow with them. It's gotta move into them, and they gotta get used to these things. That's where these cracking of the voices come in puberty, because we're getting to our adult size. The occiput is larger and rounder, which requires more careful positioning of the airway. So the tongue is larger, like we just showed you there. It is relatively to the size of the mouth and in a more anterior location in the mouth. The child's tongue can easily block the airway due to its size. A long, floppy, U-shaped epiglottis in infants and toddlers is larger than the adults. The rings of the cartilage in the trachea are less developed and may easily collapse if the neck is flexed or hyperextended. The upper airway is narrow as the funnel shape compared to the cylinder shape of the lower airway. So again, we start to think about all these anatomically changes and the size difference. We have to grow into it. Our tongue does shrink when we're growing from a child to an adult. So we're not going to have as much ability to that. Our epiglottis, our rings around our throat, those are more developed in our adulthood than they are in the adolescent size. So again, if we do flex them pretty high, or we do go to the head tilt chin lift maneuver, if we go too far, their airway may start to narrow due to that. The diameter of the trachea in infants is about the same as a drinking straw. That's pretty freaking small. Y'all think about that. That's crazy how small that is. The respiratory rate in a newborn infant should be anywhere from 20 to 60 breaths a minute. So keep that in mind. They are nose breathers. They have become nose breathers instead of mouth breathers. And that you always need to have suction handy when you're starting to deal with any type of, I personally like to bring my suction in on my stretcher along with my monitor, my ALS bag, every time that I go into somebody's home, because I don't know. Maybe dispatch got the wrong information. There may be a language barrier or something like that that has caused me to be there, but I don't have the right information. Always be prepared. It's better to look over prepared than under prepared and you have to run back to your truck. Children have an oxygen demand twice that of an adult. Whew. So think about that. They breathe so much more than we do as adults because they're little bitty lungs and they're breathing in a lot faster rate. Can anybody remember what the rate is for a child for respiratory rate?
$18, $30. You said the respiratory rate, right?
Yep, the respiratory rate.
18 to 30, right, for a child, or was it 22 to 34?
So you're going to be in anywhere between 18 and 32. It depends on the age of the child. So keep that in mind, depending if they're an infant. So as long as you're within that range and they don't look into respiratory distress, we're in a better place. They start being in any type of respiratory distress. That's when our sphincters get small and we start freaking out. So think about that. So the muscles of the diaphragm dictate the amount of air that the child breathes in. Anything that places pressure on the abdomen of the young child can block the movement of the diaphragm and cause respiratory compromise. So if we have to, let's remove that banding. Let's remove any type of clothing. We don't say like completely remove. Let's unbuckle it or lift their shirt up or something that's maybe they're compressing. Let's get that off of them. Must use caution when applying the straps of a spinal immobilization device because it may hinder the tidal volume. So again, when we put these straps on, we're not trying to suffocate them tight. We're trying to get it on and secured so they don't really slide off this board in any direction. So I always like to put a 2-finger difference. I put my hand across their chest and stack my fingers on top of each other going vertically. So that is how I know how tight it should be. That's just a personal thing. The gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. Breath sounds are more easily heard because of the thinner chest wall. Less air is exchanged with each breath, so detection of poor air movement or complete absence of breath sounds may be more difficult. You can listen to good breath sounds, watch the rise and fall of the chest fall. Those are good signs too. Think about a pulse oximetry and a O2 sat, same thing. They will help you recognize any type of distress in an early state. The circulatory system is very important that they can beat 160 beats a minute. Children are able to compensate for decreased perfusion by constricting the blood vessels of the skin. Signs of vasodilation include pallor, weak distal pulse in the extremities, delayed capillary refills, and cool hands or feet. So again, we talked about the pulse rate. So think about this. Here is your pulse rate that should be from your childhood age. All right, so the nervous system, the pediatric nervous system is very immature, it is undeveloped. It does not have any antibodies built into it yet. A head to body ratio of an infant and young child is disproportionately larger. The occipital region of the head is larger, which increases the momentum of the head during fall. So most of the time when they fall head first because that thing is big compared to their body. The subneurachnoid space is relatively smaller, leaving less cushion for the brain. So it's easier, sorry, it is very much easier for the infants to have a damaged skull, to have a skull fracture, swelling on the brain. And when they do have any of those, they are going to compensate very fast because there's no room for that pressure to go. The brain tissues of the cerebral vasculature are fragile and prone to bleeding from shear force. So think about that. We just said there's not a lot of space there. So the little knock on the head may turn out to be a pretty severe bleed because there's nowhere for the pressure to just wander around. All right, so the pediatric brain also requires higher amount of cerebral blood flow, oxygen, and glucose than the adult brain does. See, they're using all that glucose for that energy and firing off on those neurons that they burn through it so fast. A risk for secondary brain damage from a hypotension and hypoxic event are very, very possible. Spinal cord injuries are less common in pediatric patients. Here's why. The cervical spine, if the cervical spine is injured, it is more likely to be an injury to the ligaments because of the fall. For suspected neck injury, perform manual inline stabilization and follow what your protocols say. They do have adjustable pediatric collars. Some children may fit into a regular adult collar. You just need to make sure you apply the correct one. Know what your protocols say. Some agencies don't C-spine, let me put it this way. Some agencies have a less aggressive pediatric spinal protocols than others. I know some that always put the children in C-spine, KEDs, and all that anytime that there's any suspicion or a hard motor vehicle collision. The gastrointestinal system. So the abdominal muscles are less developed in pediatric patients. They are they're more susceptible to injuries from trauma. The liver, spleen, and kidneys are proportionally larger and situated more anteriorly, so they are prone to bleeding and injury caused by minimal impact. So, just completely forgot what I was going to say. Poof, gone. Sorry about that, y'all. I thought it was a good one. The musculoskeletal system. So here, a child's bones are softer than those of an adult. Open growth plates allow bones to grow during childhood. As a result of an open growth plate, bones are softer and more flexible, making them prone to stress fractures. This is where you'll get the stress fracture, the green break, or an incomplete break. And those are fixable, but they just look really nasty. Bone length discrepancies can occur if there is an injury to a growth plate. So if you damage it, you can see that there may be a substantial difference as they move up in life because of that potential growth plate fracture. The bones of an infant's head are flexible and soft. Soft spots, the fontanelle, are located in the front and back of the head. The fontanelles can be used for assessment tools such as issues as increased intracranial pressure or for dehydration. Thoracic cage in a child is highly elastic and pliable because it is primarily composed of cartilaginous connective tissues. The ribs and vital organs are less protected by muscle and fat because they just ain't got it yet. They haven't had time for it to grow. I hate saying this word. It gets me every single time. I don't even want to try. I sound like I need it. So this particular area, I ain't gonna try. Is skinny. If the skin is thinner and less subcutaneous fat areas, the composition of the skin is thinner and it tends to burn more deeply and easily, less exposure. High ratio of body surfaces to area of the body mass can lead to large fluid and heat loss. Again, we got to keep these babies covered. We got to keep them warm. We got to keep them from getting cold so they don't compensate too hard for us. So the assessment begins with the time of the initial dispatch. We know that. We've talked about that before. We got to make sure that we understand that we get the correct information en route. We start building a preliminary size up to what's going on. So plan for pediatric scene size up, bring your pediatric equipment and age appropriate physical assessment tools. If possible, collect age and gender of the child's location at the scene. The NOI, RMOI, and chief complaint from dispatch, if they have it, get all that information to where you can start making mental notes and or physical notes for your treatment and or care when you get on scene. Note the position in which the patient's body is found. Patients may be a safety threat if he or she has an infectious disease. Complete an environmental assessment. All right, so the primary objective of the assessment is to identify and treat immediate or potential life threats. And the PAT, which is the Pediatric Assessment Triangle, use the Pediatric Assessment Triangle to determine if the patient is sick or not sick. This can be performed in less than 30 seconds. What is their appearance, their circulation to skin, and work of breathing? That consists of 3 elements. We just talked about those. I'm not going to repeat that. Appearance. Let's note the level of their consciousness or their interactive muscle tone. Are they able to follow direct commands? These will provide you with information about the adequacy of the patient's cerebral perfusion and overall function of the central nervous system. The mnemonic TICLS, T-I-C-L-S, can also help determine if the patient is sick or not. TICLS includes tone, their interactiveness, consolability, look or gaze, and speech or cry. That's a new one on me. I've never heard that one. So I can't really tell you how to use that one. All right, so what is signs of increased work of breathing often present with an abnormal airway, noise accessory muscles, and they use retractions, head bobbling, nasal flares, tapnea, or the tripod position. You can also see when we talk about using the accessory muscles, that is where their stomach goes out and the stomach comes in. Those are using, most of the time we don't breathe with our stomach. That's considered an accessory muscle because they're using that to make the accessibility of breathing a lot easier with these accessory muscles. Color of the skin and mucous membranes may be a sign in the compensated shock. It may also be a sign of anemia or hypoxia. Molting is another sign of poor perfusion. Cyanosis reflects a decreased level of oxygen in the blood. Again, let's use our tools to make this work a lot better for us. So if we use a pulse ox and we can see that their O2 levels are low, we're going to provide them with high flow oxygen. So these tools are made and used to make our jobs a lot easier. Our jobs are not easy to begin with, but they help us in making our jobs a lot easier. From the PAT findings, you will decide if the pediatric patient is stable or requires rapid transport. If the patient is unstable, assess their ABCs, treat their life threats, and get them on the road to a higher facility. If the patient is stable, continue with the remainder of the patient's assessment process. Perform just the necessary interventions and discuss transportation options with the parent or caregivers. So hands-on ABCs, we talk about assess the treat and life threats as you identify them following the ABCDE, or the XABC, sorry. So extenuation, airway, breathing, circulation, disability, and exposure. That is what your XABC stands for, or ABCDE. If the airway is open and the patient can adequately keep it open, assess respiration adequacy. If they're able to do it and perform it on their own, I can allow them and give them some high flow oxygen, which allows me to do other things. So I want to know what their airway is, what's their rate, rhythm, and quality. If a patient is unresponsive or has difficulty keeping the airway clear, ensure that it is properly positioned and that it is clear of mucus, vomit, blood, or any other potential foreign bodies. Always position the airway in the neutral sniffing position. If you guys remember how I said that, it's the head and the head tilt chin lift and their nose in the upward position, like they're smelling for something. Establish whether the patient can maintain his or her own airway. I'll take another break in about 10 slides. Breathing, look, listen, feel technique. Place both hands on the patient's chest to feel for the chest rise and fall of the chest wall. Belly breathing in infants is considered adequate because of the soft, pliable bones of the chest and the strong muscular diaphragm. Bradypnea is an anonymous sign that indicates impeding respiratory distress or arrest. So in circulation, we must determine if the patient has a pulse, is bleeding, or is in shock. In infants, palpate the brachial pulse or femoral pulse. In children older than 1 year, palpate the cricoid pulse. Strong central pulses usually indicate that the child is not hypotensive, but does not rule out the possibility of compensation. Or absent peripheral pulse indicates decreased perfusion. Tachycardia may be early signs of hypoxia or shock or less serious conditions such as fever, anxiety, pain, or just plain excitement. Interrupt the pulse with the context of the overall history, the PAT, and the primary assessment. A trend in the increasing or decreasing pulse rate may suggest worsening hypoxia or shock or improvement after treatment. Again, that's why I say build these vital signs. It helps you see that trend and know what's potentially happening, if they're getting better or they're getting worse, or you start to say, oh, wow, I see they're shocky because look at their pulse, they're clammy. You know, you can recognize those early off of the assessment you've done and the trends you've created. Feel the skin temperature and moistness. Establish the capillary refill time. Use the Avpoo Scale or Pediatric Glasgow Coma Scale to assess level of consciousness. Check the responsiveness of the pupils. We need to know about what size they are. A lot of your little pocket lights or pupil lights have this solid dots on the side. And what you want to do with those dots, and it has a certain centimeter mark and all that, we want to make sure that the patient's pupils match up so we can say, okay, well, they're 5 millimeters or 8 millimeters, which is really big. So, but we want to know these things because it helps us build that assessment. The hands on the ABCs require the caregiver to remove part of the pediatric patient's clothing to allow for observation of the face, chest wall, and skin. Pediatric population is more prone to hypothermic events due to immature thermoregulation, the thinner skin, and lack of subcutaneous fat. So who else does that sound like? Sounds like our geriatric groups. So they're already going to have thinner skin, lack of subcutaneous fat, and we know that their thermoregulators are off because, God, I walked in my grandmother's house and it was 85 degrees and the heat was on. She was still cold. I'm like, God, I'm sitting there and I want to get naked because it's so hot in her house. Wouldn't have happened though. She probably would have beaten me. So infants and children should always be kept warm during transportations when the patient is exposed to assess or reassess the injuries. A lot of these times in some of these pediatric trucks, like the pediatric special trucks, they automatically have blanket warmers inside of here because it is ideal and has been proven and known that we got to keep these little babies warm. We got to keep them healthy. If they're cold, they start to go downhill a lot faster. Determine whether rapid transport to the hospital is indicated. If the pediatric patient is in stable condition, obtain a patient history, perform a secondary assessment, transport, and provide additional treatment as needed. Rapid transport is indicated if any of the following conditions exist. So you see there's a couple on your screen. Significant MOI, a history of compatible with serious illness, a physical abnormality noted during the primary assessment, a potential serious anatomic abnormality, significant pain, and an abnormal level of consciousness and or signs of shock, symptoms of shock. We'll look also for the abnormal level of consciousness. We want to know what that, if they're just not themselves, they're asking, answering weird questions, that kind of throws those red flags out there for us. On the type of clinical problems, we want to consider transportations, the established benefit of ALS treatment in the field, the local EMS system treatment and transport protocols, what is your comfort level, the transport time to the hospital, and if the pediatric patient condition is urgent, then initiate the immediate transport to the closest, most appropriate facility. Specialty facilities such as trauma centers or children's hospital have the training and staff to adequately to provide complete care for all levels of pediatric patients. They're not going to say that they're not going to be busy. Most of the time, these may be your trauma centers at the same time. The most appropriate facility is not always the closest, and ask yourself this question: can I deliver the pediatric patient to the most appropriate facility without risk or delay to the pediatric patient? If there is no, transport the pediatric patient to the closest facility and allow them to help stabilize that baby and get them on to another facility at a later time once they get them stable. Patients weighing less than 40 pounds or 20 kilograms who do not require spinal immobilization should be transported in a car seat. Mount a car seat to the stretcher. Follow the seat's manufacturer instructions to secure the car seat to the stretcher or captain's chair. A patient younger than 2 years must be transported in a rear-facing position because of the lack of mature neck muscles. For pediatric patients who require spinal immobilization, the patient should be immobilized on a long backboard or other suitable spinal mobilization devices. Again, I like KEDs for children. They work very well. They hold them down. They keep them confined. I'm not trying to say I hold their arms down, but if need be, I can put them on the inside of that KED and it's just not going to go anywhere, which is amazing. And the last one, let's see here. Pediatric patients in a cardiopulmonary arrest should be on a device that should be secured by the stretcher. You should not use the pediatric patient's own car seat. And the goal is to secure and protect the pediatric patient for transport in the ambulance. All right, before we dive off in these next four, I can hit these next four. All right, so history taken. Your approach to the history will depend on the age of the pediatric patient. So historically, information for an infant, toddler, or preschool-aged child will have to be obtained from a parent or a caregiver. Well, okay, we get that. The ability to talk to others, their cognitive ability is not there yet. When dealing with an adolescent, most information will be obtained from the patient. Sexual activity, possibility of a pregnancy, a drug or alcohol use should be obtained from the patient in private. Questioning of the parent or child about this immediate illness or injury should be based on the child's chief complaint. When interviewing the patient, parent, or caregiver, or older children about the chief complaint, obtain the following. What is the MOI or NOI? How long this pediatric patient has been sick or injured? The key events leading to this injury or illness: the presence of fever, the effects of illness or injury on the pediatric patient's behavior. How are they responding to this injury? How are they responding to having the fever? What or do they have body fever? That could be signs of an infection. Pediatric patients, their activity level, or they just blah, letting everybody hold on to them or love them, they just don't really care. We know that that's not normal. And what is their recent eating, drinking, or urine output? If this is something that they continue to act fine, they're just not themselves, they could have something else that may be particularly wrong. Changes in bowel or bladder habits. You have the presence of vomiting, diarrhea, abdominal pain. Again, that's why we want to have our suction close and handy so we can use these to move forward. Obtain a name and number of the caregiver if you're not able to come to the hospital with you. And a sample history, same as an adult. Questions should be based on the pediatric patient's age and developmental stage of life. The process for obtaining OPQRST is the same in children and adults. Questions should be based on the pediatric ability and developmentally stage. All right, guys, I'm gonna take 10 minutes here. We'll take a quick break. I show 6:58. We will be back at 8 minutes after 7. If y'all have any questions, type them in the box, and when we come back, we'll address those. We will see you in just a few minutes. All right, welcome back. Sorry about that. All right, for our sample history, we're going to do physical examinations. We know that now we're past our physicals. We're going to go more detailed. We're going to be doing this on the way to the facility, hopefully. If we have time, this should not take place on scene. All of our secondary assessments need to be done on the way to the hospital. Secondary assessment of the entire body should be used when the pediatric patients have the potential for hidden illnesses or injuries. They may be unresponsive or have a very high significant for an MOI. May help identify problems that were not as obvious during the primary assessment, but over time with them, we have noticed that they are presenting signs and symptoms and they have become more apparent. The use of DCAP BTLS mnemonic in this process during our focus exam should be performed on pediatric patients without any life-threatening illness or injuries. Infants, toddlers, and preschool-aged children who do not have life-threatening illnesses or injuries should be assessed starting at the feet and ending with the head. We've said that multiple times. School-aged children and adolescents can be assessed using the head-to-toe approach. On their head, we're going to look for bruising, swelling, hematomas, of any type of bruising. We're going to assess the fontanelle in our infants. When we talk about their nose, we're going to do nasal congestion and mucus. If we start to see this just nastiness, let's get a gentle bulb or catheter suction, and let's bring some relief to there and suck that out of there. On the ears, we're going to talk about drainage from the ears may indicate a skull fracture. In that case, we're going to get the 4x4. We're going to adapt that a little bit and lay that off to the side. Eventually, once that dries, we're going to look for any type of halo that may indicate that skull fracture. The presence of pus may indicate affection in their ears and their mouth. Make sure that they have the teeth that is required for their age. Look for active bleeding as a loose tooth and note the smell of their breath. This may indicate any type of fluid that's been absorbed. They may have a diabetic issue. We may talk about them consuming any type of alcohol. So let's make sure we assess their breath. Neck, let's examine their trachea. Let's look for swelling or bruising. If it's deviated to one side or the other. Notice the patient cannot move his neck or has high signs of fever. In that case, we're going to think about the meningitis. If we start to recognize that their neck is swollen and they do have fever, we do need to take a step back and change our PPE. We need to make it more aggressive. Because Meningitis is very contagious. So let's try to keep ourselves from that. On our chest, let's examine for let's start that over since that did not go good at all. So on their chest, we're going to examine for penetrating trauma, lacerations, bruisings, or any signs of rashes. We're going to make sure their clavicle and every rib for tenderness and deformity. We'll find out if they're ticklish or not, but we need to know that. On their back, we're going to do this one time before we put them on a backboard and or the stretcher. We're going to inspect the back for lacerations, cuts, any penetrating injuries, bruises, rashes. Rashes indicate a lot of things to us. That may be a sign of allergic reaction. So in their abdomen, inspect for distension. Gently palpate and watch for guarding. Remember, if they tell us that it hurts on one side, let's go to the far opposite side and work our way around. If you start palpating the tender area first, the entire abdomen is going to be painful. So let's not do that. Note any type of tenderness or masses. Look for seatbelts, abrasions, or bruisings during this. Down their extremities, assess the symmetry. Are they the same? Compare both signs of color, warmth, signs of joints, swelling, and tenderness. Put each joint through a full range of motion, watching the patient's eyes for any type of pain. On the vital signs, we are not able to do the infants and children. Remember, the last bullet is very important. Blood pressure is not usually assessed in anything younger than 3 years of age. Our normal heart rates are vary in age in a pediatric patient. And some of the guidelines used to assess adult circulatory status have important limitations in our pediatric, including the blood pressure. Make sure that anybody younger than 3, we do not do the blood pressure check on them. Assessment of the skin is a better indication of the pediatric patient's circulatory status. It gives us insight to what's going on. Use appropriate sized equipment when assessing the pediatric patient's vital signs. Use a cuff that covers 2/3 of the pediatric patient's arm. Here's your little formula now. The formula 70 plus. Now you take 2 times the child years in age should equal the systolic blood pressure, is a useful tool to determine some of the blood pressure in children from the age of 1 to 10. Respiratory rates are going to be difficult, but we do count the respiratory rate for at least 30 seconds and double that number. You can do 15 seconds times 4. I like doing 30 seconds, just easier math for me. In infants and children younger than 3 years of age, evaluate the respiratory rate by assessing the rise and fall of the abdomen, because it's normal for them to use accessory muscles in their normal respiratory rates. Assess the pulse rate by counting at least 1 minute and noting quality and regulatory. Normal vital signs in the pediatric patient do vary with age. If we've talked about that, we've shown y'all their vital signs, the chart that you should guys know by now. Assess respirations and then the pulse. Assess the blood pressure last. Evaluate pupils using a small pen light. Compare the size of the pupils against each other. A pulse oximeter is a valuable tool for measuring the oxygen saturation in a pediatric patient with respiratory issues. So reassessment. Reassess the pediatric patient's condition as necessary. Obviously, we want to do the vitals every 5 to 15 minutes if we know that they're stable versus unstable. We're going to keep monitoring these as we go throughout the process. If we notice any type of change, can indicate for us to do a full assessment. As we're talking with these kids or during transport, we look over and we start to notice that their lips are a little blue, that they're not acting right. That's going to indicate us to do another secondary assessment to see potentially what has changed, what is making us want to see if this now has become from a stable to an unstable pediatric patient. Parents and caregivers may be able to assist you by calming, reassuring the child. The communications are going to be relevant to our handing over our patient to the ED. because we can say, hey, look, the child's able to understand. They know they can pick this up, blah, 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 blah. So that information needs to be passed on just as important as the regular patient information. What's, who, what, when, where, and why when you go to deliver your patient to the ER. Respiratory emergencies. This is the leading cause of cardiopulmonary arrest in the pediatric population. Failure to recognize and treat declining respiratory statuses will lead to death. Make sure y'all want to understand that if you do not recognize and treat this, it is going to lead to death. During respiratory distress, the pediatric patient is working harder to breathe and will eventually go into respiratory failure if left untreated. In the early stages of respiratory distress, you may note changes in the pediatric patient's behavior, such as they start to become combativeness, they start to get a little restless, and anxiety builds in these patients. Here are some signs and symptoms of increased workload for their breathing: nasal flaring, abnormal breath sounds, accessory muscle use, and them getting into the tripod position, which allows them to breathe a little bit easier. Remember, with the tripod position, they're using gravity to their benefit, so they can lean over and gravity can help pull the chest down. And it allows that expansion of the chest wall for them to get as much oxygen as they can. So that's why that they don't like to lay in a 45-degree position. They would rather sit up and lean forward. We know that that's not a safe position for them to be in because for transportation, but we can accommodate that if that's something that is necessary. As the pediatric patient progresses to possible respiratory failure, efforts to breathe decrease, the chest rise lessens with inspiration. The body has used up all its available energy and it stores energy storages and cannot continue to support extra work of breathing. They are out of battery, basically. They have used every bit that they have and they just ain't got no more to go. Their reserve is tapped out. Changes in behavior will occur until the pediatric patient demonstrates an altered level of consciousness. Patients may also experience periods of apnea. As the lack of oxygen becomes more serious, the heart muscles become more hypoxic and the heart rate slowed down drastically. Respiratory failure does not always indicate that there is an airway obstruction, but it may indicate trauma, nervous system problems, dehydration, or metabolic disturbances. A pediatric patient's condition can progress from respiratory distress to respiratory failure at any time. A child or infant in respiratory distress needs supplemental oxygen. Imagine that. Let's deliver them 100% of oxygen as long as we're using a bag valve mask. We're assisting their ventilations, so why not? If we can allow that child to remain in a comfortable position, let's do that. As long as you keep them secured at least by a lap belt, let's make them stay in a position of comfort. Here are some things that have caused respiratory obstructions over the years. My child has put a dime in his mouth. He swallowed a quarter. I mean, but assume at some point in time, my child is going to be rich as much money as he keeps depositing. Maybe he passes it, I don't know. In case of trauma, teeth may become dislodged into the airway. Again, have McGill forceps closed, have your suction stand by, because we know that we may have to go in there and get these. That is something that we're just going to have to, if we can see it, let's try to remove it. So have those tools ready to go for suctioning and potential McGill forceps. All right, so other obstructions include blood, vomitus, or other secretions can also cause mild or severe airway obstructions. Their interactions include pneumonia, croup, epiglottis, and bacterial, what is that? Bacterial, that's bacterial meningitis. And it can also cause an upper airway obstruction. Infection should be considered if a patient has congestion, fever, drooling, or cold symptoms. Remember when I was telling y'all about croup and virus actually has the same amount of words. If they have epiglottitis, that is an infection. Think about those two different things. there's virus, and croup is the easiest way to remember that it is just a virus, versus when they say epiglottitis is going to be an infection. Those are going to be on some pretty severe antibiotics, and potentially they will hospitalize this pediatric patient to be monitored and around on humidified oxygen as they move them, because due to their severity and their could rapidly decrease in their mental status. So here's to show the figure of the epiglottis is an infection that causes the airway obstruction because the epiglottis is swollen. See how narrow that airway is? They feel like they're struggle for breathing. You'll hear them do that. There'll be more mouth breathers. They're trying to gain as much oxygen into their body as they can. And they feel that being mouth breathers is going to assist that. But due to the swelling of epiglottitis, of the epiglottis, it is just not. It's not going to get any better for them until we can assist with that. You need to be aggressive, ready to treat these patients when they start to crash. So understanding that is very, very important. Obstruction by a foreign object may involve the upper and lower airway. This may be a partial or complete. Signs and symptoms frequently associated with a particular upper airway obstruction include decreased or absent breathing sounds or stridor. Signs and symptoms of a lower obstruction include wheezing and or crackles. The best way to auscultate breath sounds in a pediatric patient is to listen to both sides of the chest at the level of the armpit. Immediately begin treatment of the pediatric patient with an airway obstruction. Be aggressive. If the patient is conscious and coughing forcefully and someone saw him or her ingest a foreign object, encourage the child to cough to clear the airway. As long as they can continue to do it, let's let them continue to cough and cause things to come up. Hang on one second. Today's my daughter's birthday, as I told you earlier, and they took my daughter out for dinner, and they're all singing, so she's happy. I'm watching. All right, so if an infant is conscious with a complete airway obstruction, perform up to 5 back blows. Remember, let's go back over our CPR. We know that this is an airway obstruction. How do we get it out? Depending upon their age, their size, their body temp, their body growth. Are we going to be able to do the back blows, or are we going to be able to hold them to do the abdominal thrust or the Heimlich maneuver? So those, when we start to get this airway obstruction, you can do the same thing in adult. Can we give them the Heimlich maneuver, or are they too big for me to just hold them up? Same way. Use a head tilt chin lift and a finger sweep to remove an object, visible foreign object, to an unconscious pediatric patient. If chest compressions are required to relieve a severe airway obstruction in an unconscious pediatric patient, then do it. It is something that we need to do. Let's get their airway back open so they can help move forward, get healthier. Let's make things better. Let's move forward on as we try to increase their survivability. Asthma is a condition in which the smaller air passages, or the bronchioles, become inflamed, they're swollen, and produce an excessive mucus, which leads to a difficulty breathing. A true emergency, if not treated, asthma can be very severe. Some common causes of asthma is natural. This includes an upper respiratory infection. Can't prevent those. Excessive exposure to cold air or smoke, or just an emotional stress can create them to have an asthma attack. Same thing for adults. Signs and symptoms of asthma. We see wheezing, cyanosis, respiratory rest, and tripod position. Treatment of a pediatric patient with asthma. Allow the patient to maintain a position of comfort, administer supplemental oxygen, albuterol or other bronchial dilators with a Hypertrum or a MDI, which is a meter dose inhaler, or nebulizer, are very beneficial but that makes sure that you need to follow what your local protocols say. And anytime that you're on a full basic truck and you go to an asthma attack, you need to have ALS there as fast as you can. They are very beneficial and will help you in your outcome of your patient. Pneumonia is a general term that it refers to an infection of the lungs. Often a secondary infection, it occurs after pre-existing infections such as a cold. Can also occur from chemical ingestion or a direct lung injury or a submersion incident. Children with diseases causing immunodeficiencies are at an increased risk for developing pneumonia. And incidence is greater during fall and winter for pneumonia. Presentation in the pediatric patient, usually rapid breathing, or will breathe with grunting or wheezing sounds. You will see nasal flaring, tachypnea, hypothermia or fever, and unilateral diminished breath sounds or crackles over the infected lung site. It is very important that you guys acquire a very good stethoscope so you can palpate all of this, auscultate all of this. Listening to lung sounds are vital for our treatment, for our care. So having a very good stethoscope that you acquire, that you not say acquire, but you get as a gift, or all these things can benefit you in your treatments. Treatment of pneumonia in the pediatric patient. A primary treatment will be supportive. Administer supplemental oxygen if required. Administer a bronchodilator if the child is wheezing. If, again, you have to go back to where if it's theirs, the right medicine, the right time, the right prescription, all those rights, I think they're what, 5 rights, the 5 R's. We have to go back to those. We have to make sure that that is, and the patient does it on their own. We can't do that for them. They have to make sure that that is done on their own. Diagnosis of pneumonia must be confirmed in the hospital. We have no ways of doing that in the field. Croup, again, is an infection of the airway below the level of the vocal cords. It's usually caused by a recent virus. It's typically seen in children the age of 6 to 3 months. We've seen it in our own children if we have them now. It is easily passed between children, so it's highly contagious. This starts with a cold, a cough, a low-grade fever, and develops over 2 days. The hallmark sign of croup is stridor and a seal bark cough. You hear that? Oh. You've heard that. It's like it's a very dry cough. We have to make sure that we recognize that. As soon as we hear it, we're like, oh, we know what that is. Here, we want to, if the ability is there, let's administer high humidified oxygen. Bronchodilators are not indicated for croup and can make the child worse. So if we recognize that, let's hold off on giving those bronchodilators because we know it's just not going to work. So let's do the best for our patient and not make it worse. Epiglottitis is an infection of the soft tissue in the area above the vocal cords. Bacterial infection is the most common cause. So epiglottitis and bacteria is the same. You want to think about that. So we talked about croup and virus, infectious, bacterial and epiglottis, so you can understand the difference. Since the development of vaccines against one organism that causes epiglottitis, is the incidence of this disease and has dramatically decreased. In preschool and school-aged children, especially, the epiglottitis can swell to 2 to 3 times the normal size. That is contagious for us too as adults. We can get that. Children with this infection look very ill. They report a sore throat and have a very high fever, which can cause seizures. They will often be found in the tripod position and drooling because it hurts to swallow. We don't want to swallow in those times. It is very uncomfortable. Bronchiolitis is a special virus infection illness of newborns and toddlers. They're often caused by RSV. It causes inflammation of the bronchioles. RSV is highly contagious and spread through coughing or sneezing. Viruses can survive on surfaces. That's why we need to make sure we clean everything, and specifically in the ambulance. We have these wipes that are cavi wipes can help go away from these things. Viruses tend to spread rapidly through school and child care centers. That's the reason why they'll tell you, if that's the case, they need to make sure that they don't bring your child back until they're healthy. These child care centers they're not being ugly, but they don't want your child because of how contagious it is, and it can shut down their facility. More common in premature infants, and the results in copious amounts of secretion that may require suctioning. This occurs during the first 2 years of life and is more common in males than in females. Most widespread in winter and early spring. The bronchioles become inflamed, they swell and fill with mucus. It's just gross. Airway of infants and children can easily become blocked, and look for signs and symptoms of dehydration, shortness of breath, and a high fever. Treatments of bronchiolitis in the pediatric patient allow the patient to remain in the position of comfort. If we're able to, some agencies don't have humidified oxygen, but it does help. And I'm going to tell you, don't just consider ALS, but let's request that, because that is something that can go south pretty fast. And we need, it's okay to say, I need help. I've said it multiple times in my career myself, is I just need help. It's fine. Talk about bursitis is a communicable disease caused by a bacterium that is spread through respiratory droplets. As the result of vaccinations, again, this disease is less common in the United States. Typically signs and symptoms are similar to a common cold, cough, sneezing with a distinctive whoop when they are during inspiration. As the disease process, the coughing becomes more severe and is characterized by a persistent whoop, which sounds during inspirations like the whooping cough. Infants infected with bursitis may develop pneumonia or respiratory failure. Treat pediatric patients. Keep the patient's airway open during transport. Bursitis is contagious, and follow standard precautions, including wearing an eye mask. So if we start this process and we know that we're getting into the winter season, we need to make sure that we change our PPE protocol. Let's go from just eye protection and gloves to, maybe eyes, mask, and gloves. So remember, what you potentially are exposed to on the ambulance will potentially follow you home. So let's not bring any of these potential exposures back to our home. We don't want that. We need to try to keep those things off of us and keep them at work. I know that's may sound funny, but again, I don't want to bring these infectious diseases to my home and potentially infect one of my children and or potentially cause a life-threatening issue because of something I brought home. I again did the same mentality is I don't wear my boots inside of my house. I will take them off. I will spray them with a Lysol. I leave them in my storage room for at least 12 to 24 hours before I bring them in the house after I work on the ambulance. Done it for so many years now. It's just common. I have a boot rack that stays in my storage room. It's just something I do. So guys, this is the end of night one. As you can see here, I will try my best to see if I can have the second portion of this class uploaded tonight. It depends on how long it takes this one to get there. So I will try to see if we can get this one uploaded along with the second one so that you potentially can watch both of them tonight, but I will try. For the ones that missed it in the beginning, I will give you an extra night, or at least I'll probably give you 3.5, probably 4 days total to take this exam because it is so big. I mean, I think the other one, the other section is a little bit bigger than this. So it's a lot. So I want you to be able to comprehend it and take it at a good time. So again, be looking out for when this is updated on the site. So I do not know when they are ever updated because our IT department does that for us. Does anybody have any questions or anything for tonight?